Okay, I'd like to welcome everyone to this evening's educational lecture. We're here in Orlando, Florida. Woo-hoo. Yay! At the Florida Hospital for Children. I'd like to tell you a little bit about CSF, and before I do that, my name is Kathy Posnick, and I am the chapter coordinator for the Chiari and Syringomyelia Foundation. I live in Cleveland, Ohio, with my husband and 3 boys. 2 of them are at school, 1's at home with me, and 2 of them have these conditions. And one, the oldest, has had 23 surgeries. He has 2 shunts. He has high pressure, Chiari, Syringomyelia, scoliosis. And I'd like to say, though, after he's been through a lot, he's doing well and he's attending college. And he is living on campus. So we are very happy about that. My second guy has Chiari, and he developed dysautonomia about 5 years after his decompression, and he is starting his first year at college. So very happy. You know, we've been through a lot, so as many of you have. So anyways, I'd like to tell you a little bit about CSF. You can read our mission statement. I'm not going to get into all the details, but all this is on our website. We're very excited. There has been a lot going on. We have recently renewed our 2-year BBB, Charity Accountability Seal. So we meet all 21 rigorous standards of the BBB. We have the GuideStar Gold Seal of Approval. And real recently, as in last week, we received the Health on the Net HON Code certification. So very huge news for CSF. Again, you can read some of this on our website. I'm not going to go into detail. We have many, many research meetings and projects. We're busy hosting various research meetings and supporting research in the fields of Chiari, Syringomyelia, and related disorders. The meetings listed on the left are the meetings we hosted for research this year alone. The right column shows you some of the research studies we have funded recently. 2 of the studies listed have already been published, and you can read about them on the CSF website under research. Our chairman and executive director just met with the engineers at Georgia Tech, another very exciting project we're working on. And they are creating a golf cart that will allow children and adults living with paralysis to stay active and live healthy lives by becoming involved in golf. If you guys have ever watched Paul's story on the CSF website, he's our chairman. He continues to play golf with Syringomyelia, and he is in a chair, so you have to watch it. It's really cool. The International Patient Database is a huge project being worked on by upwards of 50 clinicians and scientists from approximately 10 different countries. This is a great step forward in the field of research because it will allow research studies to be done with greater statistical accuracy. That accuracy will help us to prove without any doubt what really does and does not work for people with these disorders. Collaboration with other organizations is a priority for CSF. You can see that we've done a lot of work with some of these other organizations, and we will continue to do that as we move forward. At CSF, we often hear that many medical professionals have never heard or vaguely heard of Chiari malformation. There tends to be lots of frustration for people and their families who have this disorder. There are stories of people not being diagnosed for years, and CSF has created a campaign called Consider Chiari. We hope to be able to bring this out and spread it around additionally to all medical professionals about the symptoms and diagnosis of Chiari malformation, and we want everyone to have this on their radar to please consider Chiari. So this is another project being worked on. This was just a lecture that we did for some nurses down in North Carolina last year. And again, you've got our poster, The Puzzling Symptoms. CSF chapters, we're working on building additional chapters. What I'd like to tell you is be on the lookout for upcoming announcements about creating your own CSF chapter. We are working on rolling that whole program out. We've tweaked it a little bit. So you will be hearing about that real soon. Our Unite at Night. Right now I think we have 2 walk chairs in this room. Leah Kaplan from Jacksonville and Tanya Jones from Orlando. Thank you, ladies. We know how tough that is. We appreciate you. Unite at Night is a 1-mile casual evening walk, and it's to bring us together and to raise much needed funds and to socialize. And we hope you can join us next year. Here are some pictures from the walk. I do have to point out the bottom right. This was the year before last. Tanya Jones had us doing the first ever Harlem Shake. It was the Orlando Harlem Shake. And we had a ball doing it. Okay, CSF sponsored events. We have the Bobby Jones Classic. These are all on our website, but just to run through them quickly. That is our at the golf tournament at East Lake Golf Club in Atlanta, Georgia. That's coming up in May. We have the Night of Light Children's Gala. That will be November of this year. We have the Charity Ball in March. There's the gala again. Oh, the Charity Ball, sorry. Here's some pictures from it. We have the dinner dance coming up in Cleveland at the end of October. We continue to have many, many activities going on, so please check out our website. And here we go. This is our newest branch of CSF activities. Just last week, we were in Washington, D.C., and we called this our Unite at the Hill. It was our last Unite at Night walk, and we went to the Hill. There was about 25 of us, and we had probably at least 15 meetings with different senators, and it was very, very successful, and we do hope to continue to build that program. Some great information that was able to be relayed to our representatives. You know, I want to thank you for being here tonight and coming out. We really appreciate all your support, and you keep us informed about what we can do for you, and we are going to continue to work hard at our end to try to improve the lives of people affected by these disorders. So thank you. That's all I had to say about CSF. Next, I'd like to bring up our featured speaker, Dr. Eric Trumble. He is a board-certified pediatric neurosurgeon and is a director of the congenital neurosurgery at the Florida Hospital for Children. He is committed to providing his young patients with the most advanced diagnostic and treatments of congenital neurosurgical diseases by using the latest technology available. Dr. Trumble is the Pediatric Neurosurgery Fellowship. He did that in Dallas, Texas. He did his neurosurgery residency at Medical College of Virginia in Richmond, Virginia. His medical degree is from the University of Virginia School of Medicine in Charlottesville, Virginia, and his bachelor's degree in aerospace engineering is the University of Texas at Austin, Texas. So you probably get the dynamics, huh? You know, we really appreciate Dr. Trumble. He had come out to the walk to support us, and he was able to talk to people a little bit there. They have over 70 highly trained pediatric subspecialists that work with patients at the Walt Disney Pavilion here at the Florida Hospital for Children. And he has been working on a Chiari care program also. So at this point, I'd like to bring up Dr. Trumble to tell you a little bit more. Thank you.
The way neurosurgeons train is there's one board certification in neurosurgery. The ACGME, American College of Graduate Medical Education, does not recognize any subspecialties. So for those of us who do fellowships, whether it be pediatric neurosurgery like me, whether it be spine, tumor, vascular, there is a separate board for some of those, separate board for pediatric neurosurgery, but there's not a separate ACGME recognized board. So the reality is, as long as we're board certified, we're all the same. In terms of what I do, about 80% of my practice is pediatric, about 20% is adult congenital work, primarily Chiari work. So the reason that a pediatric neurosurgeon gets into Chiari is a couple. One, it is a congenital issue, so we see a lot of it in kids. Two, brain tumors are the most common solid tumors in kids. The most common location for brain tumors is the posterior fossa in kids. So we are essentially doing a Chiari approach at least weekly in any busy practice for tumors. and then you add the Chiari's on top. And so it's a location that a pediatric neurosurgeon goes to much more commonly than the adult neurosurgeons. So that's sort of got why I'm doing a lot more of this. And then this hospital put about $50 million into their OR, so I have intraoperative MRI, intraoperative CT, and whether you're 6 or 60, I'm operating in the same OR, so I've got my team who helps me. And for anybody who works with a team, you know, particularly in surgery, one consistent team leads to better outcomes. So that's a little bit of my background. I won't talk about the different types of Chiari's too much. We're going to really be focusing on Chiari 1s today. Chiari 1 is by far the most common and variable degree of severity kind of Chiari. 2's almost always seen in spina bifida. Myelomeningocele is the medical term for spina bifida. 3's and 4's very rare. They are hindbrain anomalies, but they're usually terminal diagnoses. So most of these patients don't survive past delivery. So we're going to be talking about Chiari 1s. For most of us, and I know I'm talking to a group that knows Chiari relatively well, but we're going to be talking for the camera a little bit as well. For most of us, the brain ends and the skull ends. All of our brain is within our skull. For patients with Chiari's, the skull ends and the brain ends. A little piece of the brain, the cerebellar tonsils, goes through the foramen magnum, the hole at the base of the skull. When I trained, and I remember when the first MRI came out in the mid-'80s, when I trained, any bit of cerebellar tonsillar ectopia was considered a Chiari 1 malformation. As we have matured in our ability to visualize the cerebellar tonsils, we've changed the definition. So this slide, does size matter? Size matters, but it is not the only thing that matters. And so we know statistically, if cerebellar tonsillar ectopia is greater than 5 millimeters, there is a higher likelihood that surgical decompression is going to improve your symptoms, and there's a higher likelihood that your symptoms are coming from your cerebellar tonsillar ectopia. That does not mean that patients with 3 millimeters of cerebellar tonsillar ectopia can't have symptoms. It means that you've got to make sure you're looking for other causes as well. As we are imaging more patients, essentially everybody with an MRI is getting essentially everybody with a headache is getting an MRI now. As we're imaging more patients, we're seeing more patients with cerebellar tonsillar ectopia. And so the key is to try to tease out which patients are having symptoms from their Chiari and which patients are having other kinds of headaches, stress, allergy, migraine, 80 different reasons to have headaches. So that's really becomes the key for seeing somebody who's comfortable with Chiari symptoms, try to differentiate migraine headaches, Chiari headaches, and there is no perfect way to do it. Because the incidence of cerebellar tonsillar ectopia is anywhere from 3 to 5%, about 5 years ago, the definition of a Chiari 1 malformation was altered from any bit of cerebellar tonsillar ectopia to needing to be more than 5 millimeters of cerebellar tonsillar ectopia. From a medical standpoint, that was chosen because they didn't want to call it a 5% of the population having a malformation. The reality is that's a semantic discussion, okay? So as I said, you can have 3 millimeters and have symptoms, and you can have 30 millimeters and not have symptoms. And so differentiating between the two. So this really is a semantic discussion, not a purely scientific discussion. It then gets into this whole, what do we call the 0 to 5 millimeter cerebellar tonsillar ectopia patient. So for the purposes of this discussion, I'm going to call any cerebellar tonsillar ectopia a Chiari malformation and group Chiari zeros, which most of us are calling the 0 to 5 millimeter cerebellar tonsillar ectopia, with the Chiari 1s. So again, this is just showing the cerebellum. Do we have a pointer by any chance? No. So this is showing the cerebellar tonsillar ectopia going through the foramen magnum, the pointer pointing at the herniated tonsils. Those herniated tonsils, essentially, if you picture them as functioning as a cork, that's blocking the flow of spinal fluid. So spinal fluid is made in the lateral ventricle, circulates down the third to the fourth ventricle to the spine. So when you have a spinal tap, it's the same fluid as in your head that you're sampling. If that cerebellar tonsillar ectopia blocks the flow of spinal fluid and the pressure builds up, you create syringomyelia. So that's why CSF, Chiari and Syringomyelia Foundation, often go hand in hand. And so there is a potential space in the spinal cord, the central canal, which in some 3T MRIs we can see. And so some people talk about this 1 and 2 millimeter cerebellar, 1 and 2 millimeter dilated central canal. That's not typically pathological. What we used to treat syringomyelia with was a shunt. We still do if you fail decompression. We'll talk about that a little bit more. The size of the shunt we put in is 3 or 4 millimeters. All right, so a successful decompression in the early MRI era was a 3 or 4 millimeter syrinx. All right, so sort of be aware of what we surgically consider good outcomes and not. Again, nice picture of the cerebellar tonsillar ectopia there. As you know, as Kathy mentioned, there's myriad symptoms that you can have, and that's part of the big frustration with Chiari's. This is an abnormality either of the bottom of the brain or the top of the cervical spine. Whichever way you look at it, it's anatomically the same location. So essentially, any symptom, any nerve that's leaving the brain can be affected. Classically, you have suboccipital headaches, so severe head and neck pain, classically made worse with the Valsalva. Valsalva maneuver is the medical term for anything that raises your intracranial pressure. So anything that's making your face red. Heavy lifting, strain to have bowel movement, cough, sneeze, those classically make Chiari symptoms worse. Every summer I have a couple of teenagers who come to me who say, "Doc, I'm having headaches with." And so this summer it was a girl in the choir, a 17-year-old girl in the choir who couldn't hold her note any longer because she was getting a headache. She literally was pushing the cerebellar tonsils down further. A boy football player who couldn't stay tonically extended. He was a lineman because, again, he was blocking the flow of spinal fluid. And the year prior to that, I had a trumpet player who couldn't hold the note any further. So those are sort of classic Chiari symptoms that are easy to overlook, that a lot of other docs won't make that connection. There's a classic story of a Greek general who showed how strong, how tough he was, got the army fired up because he could put his arm literally in the fire, burn his arm, and not feel any pain. His autopsy, 2,000 years ago, showed he had a syrinx. And so the pain and temperature sensation fibers are in the center of the spinal cord. So loss of pain and temperature are classic for a syrinx. And that's why part of the reason you get into the dysautonomia problem. It's both brainstem and upper cervical spine issues. All right, and then certainly as things go farther, you talk about loss of muscle strength, drop attacks, spasticity. I won't go through all those. You have all these in your handouts. But these are the classic symptoms. Kids present a little differently. Particularly in the younger kids, they often won't say, "Mommy, I have a headache." If they've been having symptoms for a long time, they may be so used to their headaches that they're not aware that this is a symptomatology on them. So we worry about brainstem findings. The number one cause of death in the Chiari patient population is sleep apnea. So in kids, we'll often pick it up with snoring. These are the kids who are snoring. They go for a sleep study. They'll find that they have central sleep apnea. A sleep study is able to differentiate central sleep apnea, meaning it's coming from the brain, from peripheral sleep apnea, meaning it's coming from enlarged tonsils or some obstruction to flow. So central sleep apnea we look for, and then incoordination. So that's sort of in the pre-verbal younger kids we see. Again, classically in headaches, in adults we see headaches and neck pain. Why do some patients go 30 years without symptoms and then start having symptoms? If you picture where that Chiari is, what's supposed to be there is spinal fluid. What is there is the bottom of the brain. That's the definition of the Chiari malformation. Brain does not have the same shock absorber capacity as spinal fluid. And so minor trauma, classically flexion and extension, can precipitate the symptoms of a Chiari malformation. So we'll often see somebody who was in a car accident who was having some headaches, but nothing that was a big deal, that afterwards started having debilitating headaches. A blow to the head, riding a roller coaster with significant flexion extension. So oftentimes we'll see that trauma precipitates the initiation of symptoms in the Chiari malformation, in the Chiari patient population. Thank you. Got it. The diagnosis is radiographic. So an MRI is the diagnostic test of choice in the Chiari patient population. One of the things that, I probably shouldn't say this on video, but I will. One of the things that my chairman in training used to say was, one MRI is worth 1,000 neurologists. Don't try to describe the anatomy, show me the anatomy. And so if there's any question, get an MRI. It's an easy thing to do. Unless you're horribly claustrophobic, you can see the anatomy very well, and it gives you a point from which to start. So as the neurosurgeon, as the guy who pays attention to the anatomy, I always want an MRI if there's any question. What you do with the MRI if you've got 3 millimeters of cerebral tonsillar ectopia, again, depends on your discussion with the patients. So once the diagnosis is made, and by the diagnosis is made, I mean you have cerebral tonsillar ectopia with symptoms potentially referable to the Chiari, what do you do? So we want to look at their history. Many of these patients will have delays when they walked, when they were potty trained. Where is their pain, and how are their fine motor skills? So I saw a woman from Alaska today who sister came in with her. She was in her mid-20s. Who said, yeah, doc, I'm having these worse headaches. She had a pretty significant Chiari. And I'm having worsening trouble walking. I've always been uncoordinated, but I'm much worse now than I was before. And so you'll get these stories frequently. Classically, fine motor skills are affected more than gross motor skills. So one of the things I ask in the school-age kids is, how's the quality of handwriting? If it starts terrible and stays terrible, it doesn't help you very much. But if it starts acceptable and gets worse, that tells you that, again, you're having progressive dysfunction. So on physical exam, we're looking for gait. What is your walk? Are you spastic? Are your reflexes hyperreflexic? So if you're having pressure from the Chiari on the top of the brainstem, you're going to have a spastic gait. You're going to, if it gets very bad, you can look like a cerebral palsy patient. But in a milder case, many of these kids will tiptoe walk. Adults will get tired if they walk for more than a couple hundred yards because they are working harder. Their legs can't relax to the same degree. And that gets to the tone. Cutaneous stigmata of neural tube defect. Embryologically, the skin and the central nervous system come from the same series of cells. And so you will often see an abnormality of the skin overlying the upper cervical, lower occipital region. Probably 70 to 80% of the patients that I operate on have a cutaneous hemangioma. So you don't see it because not many people have perfect heads like us. But when you pull the hair up, there's a little red mark in the suboccipital region. That skin was being created at the same time the Chiari was being created. In addition, you may have a sacral dimple. So if you have a sacral dimple, again, a little divot just above the anus or in the gluteal crease at the top of the butt crack, that increases the risk that you have a tethered cord or some other abnormality there. So looking for a cutaneous stigmata increases the risk. I've got a couple of families who said, yes, this was what we consider the family birthmark, the stork bite, and it's a classic suboccipital hemangioma, and they all had Chiaris. So, you know, paying attention to the cutaneous stigmata helps, and that gets back to the congenital stuff that we were talking about. Any sensory disturbance, so again, pain and temperature are the classic ones because those are in the center of the nervous system. The ones directly further out is proprioception. Proprioception is knowing where you are in three-dimensional space. So a lot of the patients will have difficulty if you close their eyes and ask them to, they look like they're drunk. You know, ask them to do the drunk walk and they look like they're drunk. The proprioception is not there. Scoliosis is something we'll often see in kids, in adults as well, but more common in kids because generally in adults you're stabilized. But that gets to our rule of 20s. 20% of patients with scoliosis will have an intradural anomaly. So unless you're the classic S-curve in a 13-year-old girl, almost all orthopedic surgeons are doing MRIs on patients now. And the reason is if you see a Chiari in a scoliosis patient, you fix the Chiari first. About half of the time, if you fix the Chiari, you can arrest the progression of scoliosis. Also, in about 20% of patients with Chiaris, you'll have some abnormality of the neural axis. So the classic ones are Syringomyelia and tethered cord. Tethered cord can take a couple of different styles. The fatty filum terminale is the one that we classically see. So remember, I mentioned the skin and the central nervous system come from the same series of cells. If a skin cell that was going to differentiate into fat failed to migrate to the subcutaneous tissue, to the skin tissue, got stuck in the spinal cord, that's a fatty filum terminale. The filum terminale is the last nerve to leave the central nervous system. Doesn't have any function anymore. We think it went to our tails thousands of years ago, thousands of generations ago. But it's essentially the appendix of the central nervous system now. We can cut it with impunity and don't hurt the patients. So that's the most common thing we see. Diastematomyelia is up a little higher. It's a duplicated spinal cord. And then a dermal tract is that sacral dimple that I was talking about. So you want to be sure you're not missing anything else. If you decompress a Chiari and you have a tethered cord, you have that tethered cord because the Chiari is being pulled down. You decompress the Chiari, what happens? You get pulled down further. You have a failure. So you need to be sure you're not missing anything else. Conversely, it's why you do a head MRI. You want to be sure that you don't have something causing the Chiari. Almost every kid with a posterior fossa tumor has a Chiari malformation. You take the tumor out and the Chiari goes back up because you've given it space. You can't push a Chiari back up in patients who have a normal brain there. And so that's when we start talking about the decompression. But it's important to do a complete neuroaxis MRI before surgery, again, to make sure you're not missing something there. You do not acquire a tethered cord. All right, you either have it or you don't have it. You may see it better at times. So if you're rail thin when you have your first MRI and you're not so rail thin after you have your second MRI, you may see that fat a little bit better. But it's always going to have been there. You just may be able to visualize it a little bit better. And again, it depends on the type of MRI that you have, right? So the open MRIs are often a 0.3 Tesla. Tesla is the strength of the magnet being used. You don't get quite as good a picture as you do a standard MRI, which is a 1 or 1.5 Tesla. And the best MRIs that we have commercially available now are a 3 Tesla. So it's a little bit bigger and a little bit better picture. So it's sort of like going from standard definition TV to HD. You can see things pretty well on all the MRIs, but you see it better on HD. So when do you decide to operate? Almost always the decision to operate, remember you got a neurosurgeon talking to you here, so we're talking about the surgical management. Almost always it's based on symptomatology. So the woman that I mentioned today who came in from Alaska said, yeah, I'm having headaches. I'm only missing 3 days of work a week, and so I think I can make it through. Everybody has their own definition of what, right. So usually, most of us, rule of thumb, more than once a week you're having issues. And that doesn't necessarily mean missing work. It just means having issues. You want to think about intervention, particularly if you've had maximal medical management. So that's one of the phrases I look for is maximal medical management. Realize whoever you're talking to has their own biases. A surgeon likes to operate. That's why we are surgeons. But you want to be sure that you've achieved maximal medical management. So if your headaches are coming from migraines and you haven't had a trial of Imitrex, that is a reasonable next step. If you have horrible sinusitis or allergies and nobody has tried to treat that, that's a reasonable next step. If you are female and have highly irregular cycle and your headaches are related to your cycle, having hormonal regulation is a reasonable next step. But if you achieve maximal medical management and you're having progressive symptoms, that's when you really want to talk about surgery. For kids, central sleep apnea plus a Chiari equals surgery. Again, last thing you want to do is have Johnny go to sleep and not wake up the following day. And that has been described. So central sleep apnea plus a Chiari equals surgery in the pediatric population. If you're having progressive scoliosis, as I mentioned, you do the Chiari first. You hope you arrest the scoliosis. Surgical repair of scoliosis is usually a top-to-bottom surgical intervention. It's a much bigger procedure than the Chiari. If you're having other neurological symptoms, so bowel and bladder incontinence, ataxia, and again, you're not finding any other symptoms, okay? So the key is you want to be sure that you've gone down any other pathway that could potentially cause these symptoms. And then you talk about decompression. Rarely is the decision to operate based on imaging. Imaging says that you have a Chiari malformation. Imaging rarely says you need surgical intervention. With the exception, if you have an enlarging syrinx, we almost always recommend surgery. Now understand that the accuracy of an MRI is only about 1 millimeter, okay? That's just simply the way that the MRI data is acquired. It's usually 5 millimeter cuts from side to side as well. So if you have a syrinx that goes from 3 to 4 millimeters, that's not statistically significant. If you have a syrinx that goes from 3 to 9 millimeters, you're talking about surgery. If you have, a precursor to a syrinx is signal changes within the corridor of the brainstem. So you're seeing enough pressure at that point that there's swelling. Signal changes is fluid buildup, swelling in that area. And the MRI is very sensitive to that. Cine studies. So cinema shows the flow through that area. And you're looking for flow at the craniovertebral junction. It is a software package that most places have now. For those who've had MRIs, and I assume most in here have had MRIs, you know that pounding starts and stops a number of times. This is just one more 5-minute sequence where they gate it with your heart rate, but they're looking for flow through that area. And I follow my patients with serial MRI. So if you're having symptoms and you have 4 millimeters of cerebellar tonsillar ectopia 1 year and 7 the next year, again, you start worrying, you start paying more attention to it. In the pediatric patient population, it's important to pay attention that growth is beyond that expected to be commensurate with the patient. So if you're looking at a kid who's 2 and a kid who's 4, you measure their fingers, toes, or anything else, everything's gotten bigger. So in that patient, you want to look, has it changed in relation to where it sits in the cervical canal? Has it gone from C1 to C2? Has it changed there? So surgical technique, and I'll talk about why I do what I do, but almost everybody, there's one group in the US now who's doing an minimally invasive endoscopic. They advertised it a couple years ago and I think stopped doing it. But almost all of us do the same thing. So a suboccipital decompression. The inion, that little bump you can feel in the back of your head, is the torcula. That's the largest veins are directly underneath there. You don't want to go any higher than that. That's the upper extent of our incision. And then usually down to the hairline. So it's usually about a 2 to 3 inch incision. We move the muscles to the side to get in. We put them back when we're done. 2.5 centimeter by 2.5 centimeter suboccipital decompression. The key to getting an adequate decompression is to give them enough space. You also want to leave shells. If you take too much decompression, there's nothing holding the brain in place still. So 2.5 centimeters by 2.5 centimeters is pretty good literature to say that that's appropriate. I do a C1 laminectomy. This is showing a C1 laminectomy. On most patients, you can make that judgment intraoperatively, but for the vast majority with more than 5 millimeters of cerebellar tonsillar ectopia, the cerebellar tonsils are going below C1, and so you need to take off the posterior arch of C1. Remember, this portion of the skull is almost at the horizontal level, so you're not really increasing the risk of damage to any trauma that occurs or anything like that. I open the dura, and we'll talk about that in just a bit, but there's pretty good literature to say that by opening the dura is the covering of the spinal cord, you roughly cut your failure rate in half. The downside of that is you increase the risk of a spinal fluid leak. So unless you open the dura, you don't have a risk of a spinal fluid leak. If you open the dura, you have a risk of a spinal fluid leak. So we'll talk about those a little bit. The majority of us will do a cytoreduction of the cerebellar tonsils using bipolar electric cautery. And what that means is we classically think of cautery that the general surgeons use, which is a tip of electricity that goes through the body and is grounded somewhere else in the body. Bipolar electric cautery is the only neurosurgeons use it really, and it's a very fine cautery. Once the cerebellar tonsils are outside the foramen magnum, they are not functional tissue. So what we're trying to do is give you sort of a nice, smooth, convex appearance to the brain again. So most will try to make the cerebellar tonsils a little bit smaller. You can't shove them back up because you've got brain there, so you just don't have space to put them back in the suboccipital region. The obex is the outflow of the fourth ventricle. So if you picture the cerebellum is two halves of the brain, spinal fluid is coming between the two. By opening that up, we're able to confirm normal flow of spinal fluid. If you don't open that up, about 10% of patients will have webbing there. You'll have scarring of the arachnoid. The arachnoid is a tissue paper thin membrane that follows the gyri and sulci, the lumps and bumps in the brain. With chronic pressure, you scar down, you get an arachnoiditis, and that's what's blocking the flow of spinal fluid there. And then you close the dura, and there's been tons of different things that are tried. There's lots of synthetic grafts. I use almost all the time autologous posterior cervical muscular fascia. And what that means is when you've made the incision in the back, you've moved the muscles to the side, the texture of the dura is very similar to the texture of skin, which is very similar to the texture of the muscular fascia, the covering of the muscle. That regenerates. So if you take a little piece of it, usually a couple of centimeters, patch the graft, they've got nothing but their own body there long term. Heals up, and in my hands it reduces the risk of a spinal fluid leak, but it still doesn't eliminate it. We don't have any way that eliminates the risk of a spinal fluid leak. So what are the successes here? About 90% of syrinxes will reduce in size after decompression. That's after opening the dura. 50 to 90% of patients will have improvement in their symptoms, and I give you a couple of articles there. But there are complications, and I'm going to go through that success rate in just a minute about why I do what I do and talk about a couple of different articles. There are complications. The risk of bleeding or infection are very low. I've done over 1,000 Chiaris. I've never needed to transfuse anybody. But there's a potential risk. If you go out too far, you have the vertebral artery, which is the arteries that feed the brain on either side. If you go up too high, you get into the sinuses, which also have a risk of bleeding. So the key is knowing the anatomy, and that gets, again, back to somebody who's been there a number of times. Risk of infection is about 1%. Everybody gets some antibiotics during the operation. Most get antibiotics for 24 hours afterwards. In general, the risk of infection for any significant operation is about 1%. Failure to improve, so we'll talk about that as well, but depending whether you go intradural or not, there's anywhere from a 20 to 40% chance of failure to improve, and that also means you want to have made sure that you don't see any other anatomical reason for the progression of their symptoms. A spinal fluid leak. So the reason that the incidence of CSF leak is higher in the Chiari patient population than, say, in the posterior fossa brain tumor population, which is literally the exact same approach, is because in the Chiari patient population, they've had pressure for a longer time. So just like water on a stone, the dura is thinned in most patients like that. And so almost always, if a spinal fluid leak develops, it is because a stitch has pulled through the dura. And what you need to do is go back and put another stitch in that dura. If all you do is put another stitch in the dura, there's no reason to think it's any better than the first time you did it. We're not closing unless we're happy with our dural closure in the first place. So if you get a spinal fluid leak, you need to have about half of the initial operation, which is going back, putting a stitch in the dura, and then I routinely put a lumbar drain in. So I drain in the back to let the spinal fluid decompress out there for 2 or 3 days. Bony regrowth. That's age dependent, and I think, I'll come to this in a minute. That's age dependent. So about 5 years ago, 6 years ago, I never saw it published, but we had the Spina Bifida Association national meeting here in Orlando, and Boston Children's presented their data, and in their hands, 50% of patients under the age of 5 needed to have a repeat operation. The reason is the body's natural tendency is to close a hole that wasn't there in the first place. The Chiari decompression is a hole in the skull that wasn't there in the first place. gave us a chance to go back and look at our data. In our hands, patients over the age of 2 are no different than the general population, which means we never had a regrowth. For patients under the age of 2, we had to reoperate about 80% of the time for a bony regrowth. You're almost always doing it in the under 2-year-old patient population in extremist conditions, meaning that they have progressive syrinx, progressive sleep apnea. You know, they're preverbal, so they're not saying, "Mommy, I have a headache." You're finding it because of significant medical issues, and so often you'll need to redo the operation on those. Okay, so I've got a couple of articles here that I wanted to talk about and tell you why I use these articles as my justification for doing what I do and why there's some controversy about why we do what we do. So in red are a couple of the results that I would emphasize, but here, this is an article. Frim is one of the senior guys, does a lot of the Chiari work out of Chicago. Again, almost a 15-year-old article now, but we don't have a whole lot newer data. And this gets back to what we'll talk about, why we need the patient registry and why we need additional data. In their hands, they looked at doing posterior fossa decompression with or without duroplasty. So this discussion we're having today is one we've been having for more than 20 years, and we still don't have a definite answer. In their hands, patients with posterior fossa decompression, C1 laminectomy without duroplasty had a 73% chance of improvement. If you had a duroplasty, you had an 87% chance of improvement. So reverse that. Here, you failed 27% of the time. Here, you failed 13% of the time. The failure rate was almost double between those two. However, their number of patients were pretty low, so it didn't meet statistical significance. There's an indication, there's a trend, doesn't meet statistical significance. So, about 6 years ago now, Dr. Durham at Dartmouth did a meta-analysis. What does a meta-analysis mean? It means that they looked at every published article that she could find, didn't use any independent data, used for the published articles, and said, should we do duroplasty or should we not do duroplasty? Her conclusion was there was no significant difference between the two operative techniques. All right, so this is what's used to say we should do duroplasty. But let's look at specific. While there is no statistical difference between the two, clinical improvement if you went intradural, 78.6%. If you didn't go intradural, 64.6%. If you have a syrinx, 87% success rate versus 56% success rate. Okay, again, reverse that. 13% failure rate, 44% failure rate. 3 times higher failure rate if you don't go intradural. So what does that mean? That means that I personally go intradural on all my non-syndromic patients. There's the rare patient, craniosynostosis, dwarfs, who are truly have skull issues. The other patients, I go intradural on all my non-syndromic patients. And the reason is every study that's ever been published shows a trend towards improved outcome if you go intradural. 0 patients papers have ever been published that show it's statistically significant. So would you choose the 13% failure rate or the 39% failure rate? Actually, 44% failure rate. That's the discussion I have with my patients. But you won't have statistical significance to it. Hopefully, if we get the database up and running and we get 10,000 patients as opposed to 100 patients, we'll get statistical significance to this. All right, so we talked about this a little bit as well. Again, studies saying that the leading cause of death in Chiari patient population is lower cranial nerve dysfunction and sleep apnea. It's very rare, but it's why we pay attention to it in the kids. I'm not going to spend a lot of time talking about these associated issues, but I will talk about them briefly. So if you're online at all, you'll see that everybody with Chiari has EDS. It is the trendy diagnosis right now. And I'll give you my 2 cents about EDS. It is my belief that the vast majority, and this is a belief, not scientifically shown, that the vast majority of patients with Chiari have some kind of connective tissue disorder. And what we're calling EDS now is a clinical diagnosis that is probably multiple genetic diagnoses coming together. In other words, it's my belief with rheumatoid factor you have a specific study for it. There is no specific blood test, no specific radiographic test for EDS. I think it's important. I think it's important we pay attention to it. I think what we call EDS right now is going to have different names, probably multiple different names in the next 10 or 20 years. But EDS is important. EDS is important for a couple of things. Connective tissue disorders are common in the Chiari patient population. That affects healing. That affects what stitches you end up using. It's important to know how they healed from any previous operations and if they had issues. If they had a significant breakdown in one of their operations, then you want to know about that. So it's important to pay attention to that. It's important to know about it. Quite honestly, it doesn't change your surgical intervention. So you want to know, but I'm not aggressive with EDS because it does not change your management. I treat everybody as though they have EDS, quite honestly. Idiopathic intracranial hypertension. So we talked about a spinal fluid leak. If this Chiari is coming from pressure from above, something is pushing things down, you will see on the MRI anatomical issues. Brain tumor, clot, hydrocephalus, fluid buildup in the head. You can't see idiopathic intracranial hypertension. So intracranial idiopathic hypertension used to be called pseudotumor cerebri. Pseudotumor cerebri is really a diagnosis in the pre-MRI era. So these patients classically have headaches, swelling behind the eyes, elevated pressure. It looks like they have a tumor. They don't have a tumor. And so that diagnosis is very difficult. When you go intradural, you get a general idea of what the intracranial pressure is. If you have idiopathic intracranial hypertension, you have a much higher risk of a spinal fluid leak. So if you make this diagnosis preoperatively, you need to treat that before you treat the Chiari. And in some patients, the Chiari will ascend. In most patients, it will not. So in most patients, you need to treat the only treatment for the most common treatment for idiopathic intracranial hypertension is a shunt. High failure rate in the idiopathic intracranial hypertension patient population. So pediatric neurosurgery didn't exist as a subspecialty until shunts were devised. The first shunt was done by Dr. Holter, who was a PhD engineer whose son had hydrocephalus in the 50s. Became common in the 70s. About 50% of all pediatric neurosurgical cases in the US are shunts. In general, we put them in for hydrocephalus, fluid buildup inside the head. Our targets are big. The shunt has about 1 centimeter of 20 pin-size holes that drain the spinal fluid out. If you have small ventricles, your target is smaller, tissue can grow in and can block the shunt. So there's about a 50% failure rate in shunts in the idiopathic intracranial hypertension patient population. So if people have interest, we can talk about that more. It is a commonly associated, well, about 5% of patients with Chiari will have idiopathic intracranial hypertension. Craniovertebral instability. So this has been a hot topic. This is something that has gotten some institutions into trouble by fusing many patients. I am very conservative with my fusion. The reason is that's a much bigger operation. We can talk about the Chiari, and the Chiari is one of the more uncomfortable operations that a neurosurgeon does. What hurts with surgery is muscle manipulation. There's not a whole lot of muscle you're manipulating up here. There's a lot of muscle you're manipulating in the back of the neck, so it's a very uncomfortable operation. When you're talking about fusion, you're talking about twice as much muscle manipulation, and then you're talking about significant bony manipulation. If you talk about fusion, and that's the treatment for craniovertebral instability, and you have EDS, you have double the healing issues. So again, it's important to have somebody who pays attention to all those things. So what happens if surgery doesn't improve the symptoms? Look for other causes. So if you have a MRI that looks good, I always do a spinal tap. A spinal tap will check intracranial pressure. A single tap has not been shown to cause further cerebellar tonsillar ectopia. So I'm pretty liberal with that. You don't want to put an LP shunt. You don't want to put something that drains the fluid continuously out there because you are literally changing the fluid dynamics and sucking the cerebellar tonsils further down. Flexion extension views are the classic views. So when you're doing most MRIs, you're laying down, or even if you're doing it sitting up, you're looking at a static picture. So when you're looking for instability, you need to have some mobility. You need to be moving the patient. Classically, flexion extension. The post-op failure patient is where I use the cine MRIs most commonly. So you may look like you've got a good decompression, but if you still have obstructed flow, there's scar that is blocking the normal flow of spinal fluid below the level of resolution of the MRI. So you can anatomically look good, and you need to look at flow. You need to look at the functional issues at that point. So if you have diminished flow at the cranial-vertebral junction, you want to consider re-exploring with concern about scar formation. Obviously, if you have a spinal fluid leak, you fix the spinal fluid leak. And it's important to pay attention to that. I had a patient who came to me last year who was decompressed 5 years ago, had serial MRIs, this is out of the state, who had been read as having a post-op seroma for 5 years. You absorb your blood after a while. Seroma is blood, is fluid. It's like a bruise underneath the skin. You don't have one for 5 years. So anyway, she had a contained spinal fluid leak, and she'd been having worse symptoms since surgery than prior to surgery. With closure, she did much better. What happens if you're paying attention to syringomyelia and surgery fails? So surgery is successful. You saw the articles there. If you go intradural, you're still going to have at least a 13% failure rate in most of the literature. So what do? First thing you do is make sure you did an adequate decompression. If you've got flow on the cine MRI, going back and looking at the cerebral tonsils isn't going to help. So that's when you talk about shunting. When I was in training, back in the late 80s, early 90s, we didn't completely understand the spinal fluid dynamics related to Chiari. So we shunted all the patients first. The issue with shunting a patient, with a Chiari, you're really working outside the brain, not going much into the brain. With a shunt, you're cutting the spinal cord in half and going into the middle of the spinal cord. So there's a much higher risk of causing damage when you go in. Clearly we know the anatomical planes, clearly we know how you minimize that risk, but that's a higher risk procedure than the Chiari decompression. So we have to put a shunt into the syrinx, and then you can put them multiple different locations. I usually do a syringo-subarachnoid shunt. So the goal is just to get the fluid out of the middle of the spinal cord. And where does it normally go? It normally goes to the outside of the spinal cord. That's the subarachnoid space. So that's the smallest shunt, but you can put it in anywhere. You can put it into the peritoneal cavity so that the extraspinal fluid is absorbed by veins on the outside of the intestines, just like fluid that you drink is absorbed by veins on the inside of the intestines. The pleura is putting it into the lungs. That's a relatively vascular area as well. And most are cervical or thoracic, so if you're right there, you can pop it into the lung if you want. These are much less common now. So this gets back sort of to the mission statement for the CSF, to advance knowledge through research. We really need to know what's the right operation. I told you why I do what I do. It doesn't mean it's automatically the best. It's just the best that I feel we have with current medical knowledge. But it may be that we know 60% of patients are going to get better if we do bone alone. Who's going to fall into that 60%? Personally, I don't want to be the one who fails, and so I do everything to make sure we give you a chance to fall into the good outcome. But we know we're going intradural on many patients that we don't need to go intradural on. So we need further research about who's going to fall into which patient population. One of the things that we're looking at now is brainstem auditory evoked potentials. Sometimes that changes in a number of these patients. A lot of people are using ultrasound looking at pulsations. Unfortunately, that hasn't panned out. But we want to document normal spinal fluid flow, and that's really what we're looking at. And then obviously we're trying to, through issues like this, educate the lay population, educate the allied population, and the medical population. So locally, most of the adult neurosurgeons don't want to deal with Chiari. It's complicated for them. Most adult neurosurgeons do spine operations. It's a whole lot easier to do a slip disc than to figure out what's going on with the Chiari patient population. So that's why they send it to the pediatric guy who's used to talking to patients for longer than the adult guys like to. That's it. Thank y'all. And I'll be happy to take any questions or sit down for a while. Does anybody have anything that they can think of?
I went to the Chiari Institute in '08, and that's where I was diagnosed and everything. The very next month, of course, I have beds to the vascular EDS. I had a bad accident, rolled 3 times, going 70 miles an hour. Can you develop a syrinx from that?
Yes.
Because I am having a lot of the symptoms you were talking about.
Yes. So you can develop a syrinx from trauma alone. Forget about the Chiari, and you put in Chiari plus syrinx. You need, and again, the diagnostic test of choice is an MRI.
Okay.
Yeah.
Okay.
But,
I'll talk to Dr. Fair.
yeah.
That's what
Yes.
I'm
You,
on. I
you,
haven't
cer-
done
you
it
certainly
last
can.
month.
You
Okay.
certainly can. Yes. Thank you all very much for coming. I appreciate the time. I hope to be working with many of y'all in the future with CSF.
Thank you.
Thank you.
Thank you so much, Dr. Trumble. Very, very interesting. Thank you all for coming out tonight. We really appreciate it. We're going to continue on with the work at CSF. We hope you can join us. We know a lot of you, are suffering with these at times debilitating symptoms, but if you can help us out, that'd be great. We're looking to raise continuous funds to continue on with some of these great programs. Thank you for being here, and again, thank you to Walt Disney Pavilion, Florida Hospital for Children, and Dr. Trumbull. Thanks.